வணக்கம். By synostosis we mean abnormal union between bones where there should have been a joint or at least a gap. This synostosis can occur at different joints in the upper limb like the humeroradial joint, the radioulnar joint, between the proximal ends of the metacarpals and also between the proximal and middle phalanx. In this video we shall be seeing all these conditions, how they occur, what is the presentation and what are the associated anomalies, because there are going to be other congenital problems that occur with these problems also. Obviously, if there is no joint where there should have been a joint, there is going to be a functional problem because there is going to be no movement. How do we deal with this? That also is going to be dealt with in this video. Synostosis is a word that is derived from Greek, where syn means together and osteon refers to bone. So synostosis basically means union of two or more adjacent bones. This condition could occur either as a congenital problem or after trauma. In this video we shall be talking about the congenital synostosis. Congenital synostosis can occur in the upper extremity at all levels because of a failure of segmentation, and can occur at more than one level, for example Apert syndrome. It can also present with another condition or malformation of the hand that occurs due to a congenital problem. And every case of congenital synostosis does not necessitate surgical treatment. We need to consider the functional and aesthetic aspects of each patient. Commonly, in the upper limb, synostosis can occur at various levels. The humeroradial synostosis, the proximal radioulnar synostosis, carpal synostosis, metacarpal synostosis, and symphalangism. We shall see all of these in detail. Humeroradial synostosis or congenital humeroradial synostosis, CHRS as it is sometimes known, refers to fusion of the lower end of the humerus with the head of the radius. It can be of two types. Class 1 is mostly sporadic. It is associated with ulnar hypoplasia and with elbow extension. Class 2 is mostly familial, associated with elbow flexion. As we have seen, in class 1 there is associated ulnar deficiency. It can be associated with other musculoskeletal abnormalities, and unilateral ulnar deficiency is more common than bilateral deficiency. Here, hypoplasia of the entire upper extremity is seen, and the ulna is partially or completely absent, and a cartilaginous ulnar enlarge may be present close to the wrist. The elbow is malformed or fused. In ulnar hypoplasia, the synostosis could be between the humerus and either the radius, ulna, or both. The radiohumeral type is most common, followed by the humeroradioulnar type and the humeroulnar type. The management of this condition is osteotomy of the humeroradial synostosis. This is done by a lateral approach to the lower end of the humerus, and we need to protect the brachial artery and radial nerve in the process. Alignment of the humerus is marked by electrocautery or by inserting parallel K-wires above and below the planned osteotomy site. A transverse osteotomy is performed at the lower end of the humerus. The distal end is flexed and rotated until the hand can be placed in front of the trunk, and the osteotomy is fixed with crossed K-wires or a small plate and screws. This shows an example of a congenital humeroradial synostosis for which an osteotomy of the humerus has been done. The selected site for the osteotomy, the rotation of the distal segment after the osteotomy, and fixation with plate and screws. And this shows the result of the position of the upper limb that can be achieved after this osteotomy. Proximal radioulnar synostosis is one of the common clinical conditions of synostosis, warranting surgical management in most of the cases. It was first described by Sandifort in 1793, but it was in 1932 when Falstrom reviewed 185 reported cases since the first description. We need to understand how this synostosis occurs. The forearm begins as a single cartilaginous enlarge and divides from distal to proximal into the radius and ulna by around the 7th week in utero. So, a failure of differentiation results in synostosis in the proximal aspect of the forearm between the radial head and the ulna. This condition is part of a spectrum of anomalies. So it could present with just radial head abnormalities to complete synostosis to even absence of the radial head. It may be sporadic or inherited as an autosomal dominant trait. It could be associated with conditions like thumb hypoplasia, carpal coalition or synostosis, symphalangism, and even clubfoot. And it could be associated with syndromes like the Apert syndrome, arthrogryposis, fetal alcohol syndrome, and Klinefelter syndrome. Children with proximal radioulnar synostosis are usually seen initially between 2 and 6 years of age with painless absence of forearm rotation, with the forearm being fixed in pronation usually or rarely supination, and a slight elbow flexion contracture. Typically, a parent or teacher notices that the child has difficulty in positioning the hand to catch a ball or drink from a cup or accept small objects in the open palm, or has trouble performing midline activities requiring the use of both hands. The delay in diagnosis is attributed to the lack of requirement for forearm rotation in infants and the use of compensatory shoulder and wrist motion to carry out these movements. Forearm rotation must be assessed at the radial styloid and ulnar head to avoid measuring rotation through the radiocarpal, intercarpal, or carpometacarpal joints. When children have bilateral involvement and the forearms are fixed in marked pronation, they have more functional limitations. In children in whom the arms are fixed in severe pronation or supination, the radioulnar synostosis can be diagnosed during infancy. Bilateral involvement is seen in approximately 60% of children, and the forearm is fixed in greater than 60 degrees of pronation in approximately 40% of patients. Children with bilateral involvement and forearms fixed in marked pronation have more functional limitations. If there is anterior dislocation of the radial head, an acute elbow flexion contracture may develop. Proximal radioulnar synostosis can be classified into 4 types based on the Cleary and Omer classification. Type 1 refers to clinically but not radiologically fused radius and ulna proximally. A fibrous synostosis is seen that doesn't involve the bone. The radial head is normal and articulating. The radial bone is smaller than normal in this type. In type 2, it is similar but clear radiographic bony synostosis can be seen. In type 3, the radius is hypoplastic with a posteriorly dislocated radial head, and in type 4, again it is hypoplastic but with an anteriorly dislocated radial head. Among these, type 3 is the most common deformity and the one most likely to be associated with significant rotational deformity, which is almost always pronation. Surgical management of this condition is warranted when the forearm is fixed with more than 60 degrees of pronation. But every patient must undergo a preoperative evaluation because the child's functional deficits and optimal forearm position for carrying out the activities must be assessed by an occupational therapist. We must remember here that movements can occur at the intercarpal joints also, so an accurate assessment by the therapist will help to determine the actual functional deficit. There are two surgical options for management: excision of the synostosis and derotation osteotomy. The procedure of excision of the synostosis has been proved to be uniformly unsuccessful. Literature has showed that resection of the synostosis and mobilization of the forearm failed in 22 of 23 forearms. Interposition of a free vascularized facial flap between the separated forearm bones may prevent recurrence of the synostosis, but the amount of forearm rotation gained is quite small. The procedure of derotational osteotomy is usually the preferred surgery. We need to remember that this surgery will only change the position of the synostosis and will not increase forearm motion. It is ideally done if there is a fixed forearm pronation of more than 60 degrees. It is usually indicated in bilateral synostosis. Unilateral synostosis does not cause sufficient functional impairment to warrant surgical repositioning in most of the cases. The timing of this procedure is controversial. Recommendations vary from before school age to waiting for the child to choose an intended occupation. The aim of the surgery is to do an osteotomy, and in bilateral cases, the dominant forearm needs to be placed in 10 to 20 degrees of pronation and the non-dominant forearm in neutral rotation. In unilateral cases, after the osteotomy, we need to place the forearm in 0 to 15 degrees of pronation. Now, what is the basis for all this calculation? A study of the optimal rotational position for a one bone forearm indicated that 30 degrees of pronation provides the best function for writing and working with small objects with the dominant arm. There are four techniques for performing this derotational osteotomy procedure. The first and most commonly used technique is osteotomy through the fusion mass and fixation with Steinman's pins or plate and screws. The second method is gradual correction with the Ilizarov method. The third technique is two-stage osteoclasis without internal fixation. And finally, we could also do an osteotomy distal to the synostosis. We shall now see how the procedure of osteotomy through the fusion mass and fixation is done. This procedure has been described by Green and Mittal in 1979. The principle behind this technique is that an osteotomy is done through the fusion mass, the desired position of rotation is attained, and the new position is maintained by one longitudinal K-wire and one transverse K-wire that is incorporated into a cast. First, a dorsal longitudinal incision is made along the subcutaneous border of the ulna at the level of the synostosis. The fusion mass is identified between the extensor carpi ulnaris and flexor carpi ulnaris muscles. Subperiosteal dissection is done around the synostosis. A smooth Steinman pin is placed from a percutaneous position through the olecranon into the intramedullary canal of the ulna under fluoroscopic control. The pin is positioned just proximal to the planned osteotomy site. A longitudinal mark is made across the osteotomy site to determine the rotation. Osteotomy is then performed with an oscillating saw through the fusion mass and distal to the coronoid process. The forearm is then rotated to the desired position. The osteotomy is now transfixed with the longitudinal pin and an additional oblique pin. Closure of the wound is done and the arm is placed in a long arm cast with the elbow flexed to 90 degrees. A post-operative X-ray shows the longitudinal wire and the oblique wires in place. There are two very important points that need to be considered when performing this procedure. The first is traction injury to the posterior interosseous nerve and the second is compartment syndrome. Methods to diminish neurovascular problems have been proposed, including resection of 5 mm of bone from the osteotomy site and even a prophylactic forearm fasciotomy. These complications are more frequent when the procedure involves more than 85 degrees changes in rotational position during the surgery. If excessive correction is needed, safer procedures like two-stage operation or ulnar shortening osteotomy need to be chosen. The next type of synostosis that is encountered is carpal synostosis. Carpal synostosis or coalitions as they are called are reported rarely, but all combinations have been reported. The most frequent have been between the triquetrum and the lunate, and less frequently between the hamate and the capitate. The incidence of carpal synostosis in a predominantly white population was seen to be 0.07 to 0.1%, whereas in a Nigerian population it was seen to be as high as 8%. It is interesting to note that despite the fact that the coalition will theoretically impair the movement at the wrist, no disabilities have been described. This condition will usually require surgical treatment only in painful fibrocartilaginous coalition where it is advised to fuse the involved carpal bones. Metacarpal synostosis was recognized and illustrated by Kelly in 1974. It is a rare congenital anomaly with wide anatomical variations. The fourth and fifth metacarpals are usually affected, and as a result, the little finger is a little shorter and in an abducted position. The synostosis is more common in patients with craniofacial and associated hand differences. You will note in this child with Apert syndrome, there is evidence of symphalangism, metacarpal synostosis, and carpal coalition. Buck, Gramco, and Wood distinguished three groups based on the length of the fusion. In type 1, there was a fusion only at the base. In type 2, there was a fusion of about half of the metacarpals, and in type 3, more than half of the metacarpals was involved. Among this type 3, in type 3A, there were separated metacarpophalangeal joints, and in type 3B, there was a common metacarpophalangeal joint. Surgical treatment of metacarpal synostosis will be required either for functional or aesthetic concerns. The abducted little finger that is usually associated may cause a functional problem because the patient may not be able to put his hand inside his pocket. But it is always better to wait until skeletal maturity to see the problems like angulation, length discrepancies, and rotation that have occurred due to growth. The procedures that can be done for the treatment of metacarpal synostosis include osteotomy alone, lengthening with bone graft or callow distraction, or longitudinal splitting combined with interposition bone graft. Symphalangism is a condition caused by failure of differentiation. It was first described by Cushing as an autosomal dominant genetic skeletal disorder. 1 year later, Drinkwater reported the anomaly because of the digital anomaly in the Talbot family in England over 14 generations. Symphalangism is characterized by longitudinal bone fusions along the finger and toe joints. Most commonly, the proximal interphalangeal joint is fused, as seen in this hand where the middle and ring fingers are involved. There could be associated conditions like carpal synostosis and stapes fixation in the ear leading to conductive deafness. Adrian, Flatt and Wood have classified symphalangism into three types: true symphalangism with the normal length of the digits, symphalangism with shortening as a part of symbrachydactyly, or associated with other anomalies like Apert syndrome or Poland syndrome. As we have seen, in symphalangism, the proximal interphalangeal joint is the most commonly involved joint with a compensatory movement at the distal interphalangeal joint and normal movement at the metacarpophalangeal joint. The distal interphalangeal joint is involved in symbrachydactyly. The anomaly presents at one or more fingers from ulnar to radial. The thumb is rarely involved. At physical examination, the fingers are slender with atrophic skin and the flexion creases are absent at the involved joints. In radiographic examination of the child's hand, a pseudo joint can be visible, represented by a cartilaginous bar between the two bones. Later in life, radiographs will show a minimal joint space due to full coalition at the joint. You can make out the pseudo joint in the index finger and full coalition at the middle and ring fingers in this hand. In this particular child, this symphalangism was associated with proximal radioulnar synostosis. Management of symphalangism is mostly conservative. Because of anomalies of flexor and extensor tendons, early surgical intervention is not usually successful. If there are well segmented joints, exploration and release of the collateral ligaments and the dorsal capsule may improve the function, but the results may be unpredictable. Arthrodesis in a more functional position of the involved joints at skeletal maturity will improve function and grip. Distraction lengthening of the stiff fingers in symbrachydactyly may improve the pinch between the thumb and a short index finger. It may lead to better aesthetics, but the treated fingers can become thin and stiff. I hope you enjoyed the video. I enjoyed making it. Please do click on the shown links to see more about the hypoplastic thumb and its management. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, plastic surgery, trauma surgery and ethics.